In Chapter 14, we're going to discuss amniotic fluid analysis. The improvements in ultrasound has now allowed amniocentesis to be a common and relatively safe procedure. There's 4 primary reasons for performing: diagnosis of genetic and congenital disorders early in gestation, about 15 to 18 weeks, either due to family history or another child born with a disorder. This will allow parents to make difficult decisions to terminate the pregnancy if the fetus does carry some type of genetic disorder. Elevated alpha fetal protein, which is a blood test done on the mom. Assessment of fetal lung maturity, about 32 to 42 weeks, to determine if it's safe to deliver this child. Estimate and monitor the degree of fetal anemia due to isoimmunization or infection, which we'll talk about later. The most common reasons are to assess fetal lung maturity and fetal anemia. And I did want to make a note here that's not in your textbook that most genetic testing can now be done on a maternal sample, as her blood does have fetal DNA, which has crossed the placenta. During pregnancy, the mother's bloodstream contains a mix of DNA that comes from her cells and cells from the placenta. The placenta is tissue in the uterus that links the fetus and the mother's blood supply. These cells are shed into the mother's bloodstream throughout the pregnancy. The DNA in placental cells is usually identical to the DNA of the fetus. And analyzing DNA from the placenta provides an opportunity for early detection of certain genetic abnormalities without harming the fetus. Physiology and composition of amniotic fluid. Formation and function. Amniotic fluid is contained within the amnion membrane, and this is the membranous sac that surrounds the fetus. Initially, it's formed by the amnion and the placenta. The composition is similar to a dialysate of plasma. The maternal circulation and plasma will contribute to the volume, transfer of water across the placental membrane, and the metabolism of fetal cells allows exchange of water, nutrients, and biochemical products. It bathes and protects the fetus by providing a protective cushioning while enabling movement. And this is why pregnant women, you get to that awkward stage late in the pregnancy where you're bumping into everything because you forget you're bigger now. And those little bumps could cause damage to the fetus. So by having this volume of amniotic fluid surrounding the fetus, it allows protection from those types of incidents. As pregnancy continues, the fetus plays a more active role in composition by swallowing, by respiration, and at about 36 weeks of gestation, urination. The composition of amniotic fluid is similar to maternal plasma with sloughed fetal cells. The volume of amniotic fluid increases steadily throughout the pregnancy, with the peak level of about 700 to 1200 mLs occurring at around 34 weeks of gestation. And I'll throw in here, 40 weeks is considered a full-term pregnancy. The fetus begins producing urine at about 36 weeks of gestation, and increasing levels of urine creatinine can be detected in the fluid. After 36 weeks of age, the amniotic fluid creatinine level will be greater than 2.0 milligrams per deciliter. This information was once utilized to determine the fetal age, but has been replaced by ultrasound measurements of the unborn child's skeletal development. Breathing movements of the fetus releases pulmonary substances into the amniotic fluid. Most notable components within these fluids are the surfactants lecithin and sphingomyelin. A ratio of the concentration of them, the LS ratio, is a reference method used in the evaluation of lung maturity and will be presented in more detail later. Specimen collection, and I have put a reference, a video of an actual procedure in the course materials. Timing and indication. Typically, amniocentesis is performed after 14 weeks gestation. However, the purpose of performing the procedure will dictate when it's done. And this is Table 14.1 from your textbook. For example, an amniocentesis to detect neural tube defects or genetic abnormalities is usually performed at 15 to 18 weeks gestation. This will allow sufficient time for the performance of chromosomal and biochemical studies, which may include culturing of fetal cells, as well as time for consideration of pregnancy termination if the fetus is determined to be abnormal. And you can't judge people. When these situations occur, the couple wants this child, and unfortunately things happen, especially genetic abnormalities, which may produce a condition in which the child is in constant pain, may not live very long, and the quality of life will be very low. So some parents will make the difficult decision to terminate that type of pregnancy. After that, 20 to 42 weeks, assessment of fetal distress due to blood group incompatibility or infection are done, and the assessment of fetal lung maturity. I want you to know when these are performed and the indications. Collection is not you. This is done by a physician, and it's done transabdominally or vaginally with simultaneous ultrasound examinations. Transabdominal is the most common. Aseptic technique with a long, sterile needle. About 10 to 20 mL of fluid are collected by the physician and placed into numbered syringes, although it varies from facility to facility. It's transferred to sterile plastic containers, as you cannot use glass, as the fetal cells will stick to the glass. The puncture heals and liquids are replenished within 48 hours. So this picture illustrates where the ultrasound mechanism is, where they can see where the baby lies so that they can safely insert the needle into an area where the fetus is not. One of the downfalls prior to the ultrasound was the doctor didn't know. It was kind of like a blind stick. And one physician I know said that she noticed that she hit the baby because the fetus jumped. These samples need to be transported to the laboratory immediately. They are stat samples. You need to protect the samples from the light, and this can be done by wrapping it in aluminum foil or putting it in a dark bag, but everything must be done to protect this from the light. Bilirubin indicates excess red cell destruction, and it is light sensitive. If you've performed phlebotomy, this should have been beaten into your head that if a bilirubin is ordered, you must protect that sample from the light. Failure to protect from light may cause a false decrease result, which may result in failure to intervene to save the baby's life. Storage, cell culture, chromosomal studies, microbial or viral cultures, keep the sample at room temperature. Fetal lung maturity tests are done ASAP or stored at 2 to 8 degrees. Amniotic fluid may need to be centrifuged prior to analyzing. Sometimes a woman will notice that she's leaking fluid, and it's really important to differentiate whether she's leaking urine from leaking amniotic fluid. So the differences are, you would test the fluid, that the amniotic fluid will have glucose, protein, and the creatinine level is similar to plasma. In urine, there's essentially no glucose or protein unless the patient has diabetes or kidney disease. There will be a high creatinine and a high urea. So these tests are done to differentiate whether she's leaking urine, which is not cause for concern, it's just a pain, or amniotic fluid, which may result in an intervention. Physical examination, the normal amniotic fluid is either colorless or a very, very pale yellow. Yellow or amber colors is due to increased bilirubin. Dark green is meconium from the fetal intestine. It's similar to stool, but it's specific for a fetus. If it's pale pink to red, this could indicate blood or hemoglobin that may be present either due to a traumatic tap, an abdominal hemorrhage, or intraamniotic hemorrhage. Dark red-brown, probable fetal death has occurred. All amniotic fluid is somewhat turbid early pregnancy, there will be little particulate matter, so it will be very low turbidity. Later on in the pregnancy, it's more turbid as the fetus has released cells, hair, and vernix, which is this really gross looking stuff that coats the baby during their time in utero. So from left to right, you see the first two fluids appear normal. And then the three examples of bloody amniotic fluids are shown. So blood-tinged fluid is not uncommon and can be due to contamination with maternal blood during the collection of the sample. Usually the blood is of maternal origin, but if there has been trauma to the abdomen, it may be fetal. We had a woman one time who got hit with a football at a football game, which was really sad. And it was okay. The baby, it turned out okay. Flow cytometry, or the traditional Kleihauer-Becky stain, can determine the presence of fetal red cells. So we'll talk about this when we get to the course immunohematology. So cytogenetic analysis, it's determination of chromosomal abnormalities and certain metabolic defects. The cells can be cultured and chromosomes evaluated for the appropriate number and completeness. Some cells lysed and the contents analyzed for enzymes to evaluate for metabolic defects such as Tay-Sachs, which you need to do a Google search because this is a very, very sad disorder, and most parents will elect to terminate the pregnancy. It's not done on all patients. Patients that are greater than 35 years old, or have a history, or if there's an increased alpha fetal protein test, or if they're known carriers. A neural tube defect is an opening in the spinal cord or the brain cavity that occurs during the first couple weeks of development of the fetus. Neural tube defects are one of the most common birth defects, occurring in approximately 1 in 1,000 live births in the U.S. Fetal neural tube defects such as anencephaly, the baby has no brain, or spina bifida, the spinal column is outside, will cause an elevated alpha fetal protein, or AFP, in both the amniotic fluid and the mother's circulation. And I chose not to have the AFP test because termination of pregnancy was not within my belief system. Well, my sister decided she would have an AFP. We were pregnant at the same time, and she went back to the doctor, and without really any explanation, they came in with this super long needle, and my sister said, "What's going on?" They said, "Well, your AFP is elevated," and most of the time it is a false negative type of situation, but in order to ascertain whether it is or not, we need to draw blood from the amniotic sac. And my sister said no. And that's what you need to think of in medicine, whether or not to have a test. What will you do with this information? And again, if your belief system is that you'll carry the baby to term, why get it? So she spent the last trimester being very worried about the health of her baby. Turns out everything was fine, but again, you have to think about the consequences, and doctors need to really explain these procedures to patients to whether or not they want the test done at all. In normal fetal development, AFP peaks at about 16 weeks of gestation and then declines gradually to term. With neural tube disorders, the neural tube is open and AFP is released from the cerebrospinal fluid that leaks directly into the amniotic fluid, and the amniotic AFP levels are much higher. Testing for amniotic acetylcholinesterase is more specific than AFP and is sometimes used as a confirmatory test. These tests are affected by the presence of blood or hemolysis. Now let's discuss the chemical examination. Fetal lung maturity is one of the #1 reasons we test amniotic fluid. The pulmonary system in the fetus is one of the last organ systems to mature. Tests predicting fetal lung maturity and assessing the risk of developing neonatal respiratory distress syndrome, RDS, when performed during 32 to 39 weeks. Testing is of no value at less than 32 weeks. All FLM tests will indicate immaturity at this stage of development. RDS is the most common cause of death in the newborn. RDS results from insufficient production of surfactant in the newborn's lungs, which we'll talk about that in a moment. So why do we test for fetal lung maturity? Testing is done to determine whether the fetus is capable of surviving an early delivery. Some babies born premature do just fine, others unfortunately don't. Hyaline membrane disease is also called neonatal respiratory distress syndrome, RDS. It's a major complication of premature delivery, and this results from insufficient production of surfactant, which we'll talk about in a moment, in the premature newborn's lungs. Lung surfactants allow the lung alveoli to open during and when breathing. If they're unable to do this, the baby doesn't get enough oxygen and bad things happen. RDS is the most common cause of death in premature newborns. The role of surfactants is to decrease surface tension in the alveoli in the lungs, permitting inflation. If surfactants are decreased, the small alveoli will collapse. Fetal lung surfactants include 3 phospholipids, which I want you to know the names of. Lecithin, which is also known as phosphatidylcholine, is a major lung surfactant. Sphingomyelin and phosphatidylglycerol. Many tests are developed to assess these 3 phospholipids to determine lung maturity. So these tests are designed to determine the probability of respiratory distress syndrome. The correlation between fetal lung maturity and the level of these specific phospholipids, also known as surfactants, in the amniotic fluid is crucial. The probability of RDS is determined by 2 factors: the results of the fetal lung maturity test and the gestational age of the fetus at the time of testing. A recommended testing is a cascade approach where a series of FLM tests are performed until a mature result is obtained or all tests have been performed. The lecithin-sphingomyelin ratio is performed on the amniotic fluid to check for lung maturity in the fetus. The lecithin is the major lung surfactant. We don't know for sure what sphingomyelin's role is in the lungs. At 33 weeks gestation, the LS ratio is at approximately 1:1. After 34 weeks, lecithin production greatly increases as compared to the sphingomyelin. An LS ratio is 2.0 or greater for lung maturity. This means there's 2 more times lecithin as sphingomyelin. And the reason for doing these tests, once a baby's lungs are deemed mature, then an early delivery can be performed. An LS ratio of greater than or equal to 2.0 indicates maturity of fetal lungs. This is determined using a thin layer chromatography technique. The presence of blood in the specimen decreases a mature result and increases an immature result, so those results are not reliable. Meconium-contaminated specimens should not be used, as, again, the results will be unreliable. This test is a better predictor of lung maturity than immaturity. Phosphatidylglycerol is another test that's used to determine fetal lung maturity. It's not detectable until 35 weeks gestation. The techniques include thin-layered chromatography or a slide agglutination using anti-PG antibodies. So in this case, the PG would be the antigen, and we have a reagent, anti-PG, that we add agglutination positive. Positive tests are very specific, but many false negatives do occur. The PG test is not affected by blood or meconium. I didn't know much about lamellar body count, so I had to do a little bit of research, and it turns out that pulmonary surfactant is packaged into lamellar bodies, and these are excreted into the alveolar space. During the 3rd trimester, these bodies are present in the amniotic fluid in amounts of 50 to 200,000 per microliter. Greater than 50,000 per microliter indicates fetal lung maturity. Lamellar bodies are about the size of platelets, so they can be counted using an automated hematology counter's platelet channel to measure. You can't use a bloody specimen because it's whole blood, and it will falsely elevate the lamellar count due to platelets. It's rapid, low cost, and a small sample size is needed. This is a picture of a lamellar body through an electron microscope. Looks pretty cool. These are the interpretations based on the lamellar body count, with again greater than 50,000 per microliter indicating fetal lung maturity. The foam stability index is also known as the shake test. To perform this test, dilutions of the amniotic fluid is made by mixing equal volumes of the fluid and then adding differing volumes of absolute ethanol, and then that's vigorously shaken. If adequate amounts of surfactants are present, a stable foam is produced, which remains for at least 15 minutes. The highest concentration of ethanol with a stable foam is the foam stability index. Fetal maturity is indicated by an FSI of greater than or equal to 0.47. It's rapid, it's easy to perform. Blood and meconium will produce inaccurate results. Because I didn't know much about this, I had to find a picture. So on the very left-hand side is a positive result. You see a lot of foam. Intermediate, there's a little bit of foam at the top, and then negative, there's no foam. Our last topic, your book calls Test to Detect Blood Incompatibility, which is kind of a misnomer, but it matters not. We'll call it that for now. Hemolytic disease of the fetus and newborn is one of the primary reasons we do an amniocentesis and test it. This topic will be presented in great detail during the immunohematology course. HDFN occurs when the mother makes an antibody against an antigen on the fetal red cells that she does not possess. Of course, where did the antigen come from? The father. During the immune response, again, this is why you need to remember primary versus secondary immune responses, because it's really important in HDFN, because in the primary immune response, the antibody class produces IgM. This cannot cross the placenta. Then, as we transition through the primary immune response, we get the transition to IgG class antibodies, which can cross the placenta. The first antigen-positive child is not usually affected or is mildly affected due to the time it takes to produce sufficiently high titer IgG antibodies. And what this antibody is directed against is an antigen on the fetal red cells. What is the role of antibody coating? It's to destroy the antigen. So the red cell becomes destroyed due to this antigen-antibody reaction. If the mother gets pregnant with another fetus who also has the same antigen, then the secondary immune response kicks in, and the fetus has the potential to suffer severe hemolysis due to the rapid increase in IgG class antibodies very early on in the pregnancy. The most severe type of HDFN is caused by Rh negative mothers who become pregnant with an Rh positive fetus. So this illustrates the first pregnancy versus the second pregnancy, and again, the fact that the first pregnancy is the immunizing event where the mother is exposed to these Rh positive cells. Then the second pregnancy, unfortunately, she knows how to make the antibody, high titers of IgG, which will then coat and destroy the Rh positive cells. Determination of the severity of the HDFN is predicted by measuring the amount of bilirubin in the amniotic fluid in a spectrophotometer set at 450 nanometers. Normally, bilirubin is undetectable in amniotic fluid. It becomes increased if there is significant hemolysis of the fetal red blood cells. The amount of bilirubin present correlates very well with the severity of hemolysis. Normal amniotic fluid has a straight line when absorbance is scanned from 365 to 550 nanometers. Bilirubin causes an absorbance peak at 450, which is why we set it at that. Bloody specimens are not acceptable for analysis as oxyhemoglobin absorbs at 410 to 540 nanometers. Meconium-contaminated specimens are also not acceptable as it causes interference with drawing the baseline. Again, bilirubin is very light sensitive, so it is essential that these samples are protected from the light. Failure to protect from light may cause a significant decrease in the bilirubin, leading to failure to treat the fetus, which may result in death. These diagrams are in your textbook, and this is determination of bilirubin levels at 450 nanometers in amniotic fluid. The top picture, A, is normal amniotic fluid. B is amniotic fluid with the bilirubin peak at 450 nanometers. And then C is amniotic fluid with the bilirubin peak at 450 and contaminated with oxyhemoglobin, which peaks at approximately 410. So this is the dashed line that indicates the baseline drawn between the linear portions of the curve between 365 and 550. The red line indicates oxyhemoglobin absorbance. This is a Liley graph that is based on the reading of the amniotic fluid at 450 nanometers versus the gestational age of the fetus. In zone 1, it's divided into 3 zones. Zone 1 is normal. Zone 2, it's getting severe. And zone 3 is it's severe. Immediate interventions need to take place, whether it's intrauterine transfusions if the baby is too young, or if it's deliver the baby now based on the fetal lung maturity test. This is a similar type chart. It's called the Queen Anne chart, which is new to me. And it's also used to evaluate the severity of hemolytic disease between 14 and 40 weeks gestation. And it divides it into 4 zones, indicating the severity of the hemolysis. So on the bottom we have unaffected. The second is indeterminate. We need to monitor, see if the bilirubin levels still go up. Rh positive is, the third zone is Rh positive, definitely affected, so decisions need to be made. And then the top one is intrauterine death risk. So that would require some instructor. Also read your textbook.